Okay, so let's start. Perhaps some people will join us, but given the time, I think it's good to start with this breakout session regarding e-health or identity in healthcare. That's the topic of today's afternoon session. It's a topic that we didn't have discussed already yesterday on the first day of the IDnext event, but especially if we also see where we are now, where we are coming from the last 2 years for essentially, but also the last 20 years with development within healthcare. I think it's also an important topic to discuss. So it's great to have 3 speakers today who are going to tell their experience and developments regarding healthcare. So the first speaker, Nupur, and I hope I will pronounce it correctly, otherwise I will get punished maybe. So great to have you here. She's going to tell us about responsible use of artificial intelligence in healthcare. According to her biography, a healthcare leader, medical doctor, author, innovative speaker, supervisory board member of Unicef, the Netherlands, but also member international advisory of the Amsterdam Economic Board. Currently medical advisor with the largest healthcare insurance company in the Netherlands, and she's also the curator president of Global Shapers, World Economic Forum in Amsterdam 2021, and also a team member of the World Economic Forum Chatbots Reset Project and Generation Artificial Intelligence Project. So quite a busy life, I think, at that point. So I would like to welcome you forward for your presentation about responsible use of artificial intelligence in healthcare.
Yeah, thank you so much for, and I think this one is working.
Yeah, and I think if you do this on, then the clicker also should work.
Yeah, wonderful. Thank you so much for, joining me and the other speakers here today in this breakout session. So as was said in the introduction, in my daily life, I'm actually busy with the financing of our hospital care and expensive medication with Achmea. So that's the big insurance company, and Achmea has Zilveren Kruis. So I always represent them with deciding what prices we should put on our healthcare in the Netherlands. And also in the insurance business, we're busy with digitalizing healthcare. But today I will actually take you more within my role that I had at the World Economic Forum, because I have been, as was said in the introduction, been involved in setting up 2 types of frameworks, and one of those frameworks was called Chatbots Reset. And what we did there is that we built a framework for governing responsible use of conversational AI in healthcare. So conversational AI, as some of you may know, are the chatbots. But of what kind of principles and rules should this artificial intelligence adhere to also be successful? And that's also what I will be telling you today. So this project started last year, August 2020. In the time until March, we have been building this framework, and at the moment there have been several pilot phases throughout the world, and the biggest one is now running in Rwanda, where they are looking at how to apply this artificial intelligence in combination with the human agent, as we call them, to deliver better health care to the patients there. So what is responsible artificial intelligence actually, and why is it so important? Responsible AI is part of AI governance, and AI governance has all to do with artificial intelligence being researched well, being developed well, but also doing that in a sustainable way. We want that artificial intelligence to exist for many years to come, and also that it is understandable for not only the user, but also the developer and the regulator, on which I will also be speaking a bit more later onwards. So I studied medicine, and I always thought, why are we not applying technology more? It always feels such an interesting but also difficult journey in the Netherlands. And not only in the Netherlands, but I think in many parts of the world, we are not even thinking about applying technology in certain ways yet, while it doesn't have to be that difficult. So a little bit of insight in why not only I, but also several articles believe that we should start using artificial intelligence in healthcare. So some articles say that it would be especially helpful for physicians who are feeling burnout from the past 18 months of the pandemic. It says physicians. However, in the pilot that we are running in Rwanda, especially nurses are working with the artificial intelligence to take work away from the doctors. I would really like that in some articles we would speak a little bit more on what kind of paramedics or assistants of the doctors could use artificial intelligence in such a way that physicians could make the super specialized decisions especially. Then the second point says, with AI, physicians can create personalized and engaging experiences, which assists in the clinical decision-making process. While this is true, my personal view is that there's also a responsibility that we educate, whether it's the patient or society also in general, to make that possible for the physician. So this is more a soft side of where do we put that identity, if we call that so, if we want to make artificial intelligence successful. Then in one of the other articles, it also said, artificial intelligence can drive down the cost of care and improve research and collaboration efforts. While this is true, if I put the hat on of the healthcare insurance company, I would say, yes, this is exactly where we want to be. And I believe that one of our other speakers will also talk about it today. It's very important, again, to not forget the patient behind it and how, when we are talking about personalized care, can also keep a human aspect in when we use artificial intelligence. So this is a little bit what I wanted to say about this. And as already mentioned, in many places, artificial intelligence is already implemented in a way, but a lot of places are still in the beginning stage. So why did I put this here? When we start digitalizing, we can either do that in big specializations in hospitals in the Netherlands, such as cardiology or even surgery, or when we look at other big groups, we look at the physicians, the general practitioners. However, there's another project running with the World Economic Forum that looks at healthy aging. And maybe not only for the people sitting here, but also in general, we should think of, when we look at our nursing homes, how this artificial intelligence can also be useful there with the human aspect. But then, not only the aging, but the healthy aging part. How could artificial intelligence assist there? Just to give you a few examples before I come to the actual principles. So all of this for me is a part of responsible digitalization. And not only a responsibility for the regulator, not only for the provider, but maybe for us as a society in general. Responsible artificial intelligence is actually a combination, and that I will show you later as well, of ethics in healthcare and also ethics in technology. And it is supposed to address the gap in making artificial intelligence systems more transparent, that's one of them, reliable, but also to be better interpret them, so we can address organizational and societal issues of fairness, bias, legal things that come there, compliance is there, and ethics in a methodical way. That's what Accenture tells us. And there were actually a few more things that I wanted to tell you here. Yes, and what I find here very important is the part of trust. Because when we talk about transparent and reliable, it all comes down to trust. Are we ourselves trusting our digital systems, and where does that trust come from? These are the 10 principles that we have set up, and I can imagine now looking at it that it is quite small, so I will only really short, because I only have 20 minutes today, go with you through it to explain a little bit what we found especially important things of these principles that are created from both an AI ethics perspective as well as ethics in healthcare. On the top, we see safety and non-maleficence. With that, we mean that when we develop any digital system, there should be no avoidable harm. So we made it very general, but whoever will use this framework should think, what is avoidable harm when we talk about implementing any digital system? There's a lot more to say about it, but I will only go very short through it. Then we also looked at efficacy. So efficacy is also what kind of rules should institutions follow? How effective can this artificial intelligence be in combination with whatever comes in all the other aspects that we have put here? Data protection is a more common one. You would expect this principle to be there. But data protection also all has to do with consent, and also to be able to track back where the original input came from. And are we able to really be open about whatever we are putting in the system? Not only that, how are we disposing this information? To me, when I was busy building this framework, I said, okay, well, it's getting there, but when do we talk about how do we dispose whatever data is there? The next one that we see here is human agency. Human agency is one we might forget. We think, okay, well, we have no use of technology, then we have technology, but how is this technology assisting the human? But also, how is this human being trained? Can this human understand what the technology is trying to tell them? So the important question with human agency will be, how will this digital system actually support? Until what level is it needed? Then we have accountability. And accountability, I will come back to that in the end as well. Because who in your organization is actually accountable for what this system does? Is this only the IT person? But if you look at it from a legal perspective, how much accountable are the board members or even the patient, him or herself, or the doctor who is using it? Every person who has been using it, what kind of accountability can we put on that person? Transparency. Transparency has a lot to do with data protection, because where is this data used for? But also, is it clear if a person is interacting with the patient, if we're talking about chatbots, or is it purely only the technology? And then there's another way. You can have the technology starting and then the human interfering. Is it clear for the user, whatever the literacy level is, when the human starts interfering with the technology? With fairness, we mean no bias. What are these biases? Fairness, I will not talk about that too much because one of the other speakers will talk about that also. When we talk about explainability, we talk about, can this decision be explained to the user? And can the user also explain the decision of the technology to the patient sitting in front of them? With our pilot now in Rwanda, what we are doing is the nurse is using the AI to put the symptoms in the system. Then the system says in the end, this is the diagnosis. The nurse can then decide, how do I interpret it? Do I follow that decision, or do I follow my own human decision? She can say, no, I'm not using the decision of the artificial intelligence. I'm going forward with my own decision. In this, we also said, is the artificial intelligence system being able to explain why the decision was there. Should we build an algorithm for it or not? Or should we just rely on that she understands what the system says? Integrity. Integrity is, for me and also for us here in the report, that is everything that is been put in the database is that evidence-based. Evidence-based medicine is what we have to rely on at all times. And then really short about inclusiveness as well. With inclusiveness, also when I look at it from my role in Unicef, is are even people with a lower literacy level, how accessible is our digital systems for these people? If we have children with psychological problems, are they able to even interact when we talk about artificial intelligence when they are chatbots? But not only that, if you would, for example, put that in toys, are they able to access it in such a way that it's not harming them? So this is very short, our 10 principles, and I will look at you, how much time I still have left.
You still have 5 minutes.
Okay, well, that will fit. So what do we do? For these 10 principles, we have looked at what is the role of the regulator, so our government per se, what should they do? What should the developer do, so the developer of the software itself? And what are the perspectives of the user? So user is twofold. It will be either the physician or the nurse, or it will be the patient itself. What is important for them? What might be less important for them? Where are the hurdles here? And then we had another matrix which says develop, deploy, or we would evaluate what was happening within the system. Also keeping in mind that you have another spectrum of only letting the humans do things, have a hybrid version, the technology and the humans keep interacting all the time, or you give the technology all the responsibility to interact with whatever user is there. So really short, what role does then AI ethics or ethics in technology have in your company? Because at this conference here today, we're talking about identity, and that has all to do with the ethics that I just spoke about. First, of course, is make a start. And why I said make a start is that planning here is very crucial. In whatever way you would also like to implement something new, we realized in also other pilot projects that later on, the planning cannot be changed just like that, especially when you want to scale up a certain digital project that you started. I want to put a little bit more emphasis on this. This is something that is very much underrated, the education and training part of whatever human is interacting or trying to learn. I'll give you an example, not of the Netherlands, but in many African and also Asian countries during the pandemic, a lot of people actually passed away because there was a shortage of staff who did not know how to run certain technical programs or technical instruments, or felt they had a lack of education when they had to do that in an urgent situation. For that, we need awareness, and I would like to look broader at society as a whole. If we are talking about public health, so we're not talking about hospitals anymore, but the general practitioners. If we take it further to a more broader prevention level, what could we do there? And the keep improving part. Yeah. So what is actually the idea that every company should have? A responsible AI ethics council. There should be a special council that interacts with either the executive board or the executive committee in the future that keeps monitoring how responsible are we using our digital systems, and are also accountable for that in their yearly reports. So that is actually what we would like to work towards too. This is something I would like to give you to think about. So what role does AI ethics or ethics in technology have in your company? And I think I'm still within my time.
Thank you. Are there any questions?
Yes.
I would think that it's fairly unlikely that AI chatbot technology will be run and operated by individual practitioners and even individual companies or hospitals, or so this will be offered as a service typically. But ultimately, of course, an AI is a program. And so how do you make sure that you can apply whatever responsibilities and ethics you have in your company and in your practice? How can that be applied to an AI as a service concept? Do you have any ideas? Any suggestions?
Yes, well, with the thing that individuals, if they can do it well, you have to look at consortiums then. I mean, of course, a general practitioner all alone, that might not be the stage where we are at. But if we can apply it now in several countries in Africa where we have the nurse at the emergency ward being able to use this, I think it should be possible. However, there's a task here for the developer. So the developers should ideally be more involved than in the clinical institutions themselves. They're now, what I know, still quite separate entities. So there should be a bigger interaction there to make that responsible use of AI possible. And then, of course, if you have a special counsel for that, where you will have both behavior specialists, technology people, doctors, they could keep an eye on where it happens. Ideally, you would like to have that in your national AI strategy. The Netherlands has a national AI strategy, which many people may not know about, but in other countries, such aspects are within their national AI strategies, how that should happen. So are more also on a regulator level.
I just had a question on the nurse story that you were telling. So if she decided not to follow the advice from the AI, does she also give that information back to the system? Like, I don't want to apply the solution that is given to me, and these are the reasons why I will not deploy it? Or is not that the way that it works?
So in the end, she gets a mini survey on did you follow the advice of the AI? And if she did not do that, she can put it there. And at the moment, the system is not correcting itself. So the developers, a person like myself, and also people from the board of this technology company, they sit together and we now go manually through what they've given us back, and then make a plan how to improve the AI as such that they might want to follow it the next time.
So this is AI without machine learning?
No, there's also machine learning involved in that in a later stage.
You could apply machine learning to the feedback from the nurse.
Yes.
Yes, but then the input can be biased by the nurse.
Yeah.
Also, but no, at the moment it's not the machine learning yet, because we want to see if it's right at the basics. But that would be ideal for a next phase or a next stage.
Any other questions? Because I had the same question, and I guess you don't have any benchmarks yet based on those surveys.
No, we had smaller pilots with only within the technology company. So a company in Germany, a company in India, and a company in the US who only have looked within their own technology company, like, hey, would my employees like to work with these principles? But this is the first time we're actually piloting it in like a ground setting. So no, we don't have benchmarks.
And do they appreciate it or not? Is it welcome as a solution, or don't they appreciate the fact that they have no technology helping them in their job?
So currently, maybe because it's Rwanda, the nurses are just following. They did not say we don't want to do it. They're just following the program as such. However, I have not asked them what kind of other feedback there was, so I don't have an answer to that yet, but we did not hear any negative things. But I can imagine if you would do it in the Netherlands, where we are more like oh, should we do this? Or is it difficult? We might get other reactions, but it's not started here yet.
Which use cases or which areas do you see this applied in the Netherlands in the near future? Do you think there are use cases which we can apply this already?
So now they're doing it in the emergency ward. So the idea would be that you can take faster decisions at the start of the emergency ward. That's now that's not now what we're looking at, and you could do the same for huisartsenposten, the general practitioners' posts, where we see there's also quite some pressure.
And the medication?
That could be a possibility, definitely, as well. But that is, well, it has not been a priority yet. I mean, you can pilot it at many places, actually. So we could talk about that.
Okay. Well, last question. Did also COVID give an acceleration on the things that are now being done, the artificial intelligence, yes?
Yes, it definitely did. We could actually speed up this project more and actually got more funding.
More incentive in order to do this?
Yeah, because of COVID. You could actually look up the report and go through it as well, where we actually talk a little bit about that.
Yeah. So there's a contradiction, because you need incentive like a pandemic in order to get this done.
Here we definitely noticed it, because before I came there, this was already lying there for quite some time.
Yeah.
And only since last year, I think April, we could speed up the process a bit.
Okay.
But incentive is the word of the day, I have the impression. It's true.
It's normal.
Okay, thank you. And in this next presentation, that will be done by Tim Franssen. And Tim is board member of the Nudge Foundation since day one, so really the founder of this foundation. An initiative which is a community of IT healthcare, IT suppliers, and also supporting foundation that together works towards a reusable, flexible, simple, and also safe, decentralized infrastructure, especially for data exchange in the healthcare sector. So Tim is going to talk more about self-sovereign identity as a tool to take back control over your medical records. So that is also an interesting topic, where we just heard a number of things about artificial intelligence, but now really something to, let's say, the end user, the patient, in order to get control of your medical records. So in this talk, Tim will explain a bit more about the Nudge initiatives, how they get to that point of setting up this foundation and what they try to achieve, and also about principles in SSI and what they couldn't do this without SSI or even with SSI. So I think everything's being said. You have water, you have a clicker. So
thank you. Excellent service.
Good luck.
Thank you, Robert. A very good afternoon, everyone, and thank you for being here. I'm very honored to have you all. I'm going to talk about self-sovereign identity as a tool to take back control over medical records. And I made this title a week ago, and this week I was working on the slides, and I thought, well, it might also imply that there's no control over medical data now, and that's not really the case. Of course, there is control, but control is now mainly in the hands of IT suppliers, of like centralized institutions that govern the data exchange, at least here in the Netherlands. What I'm advocating for is more of a system where we, as like the patient or the caretakers, givers, but also the medical professionals, will have more control over how their data is managed, right? So my name is Tim. I'm one of the founding members of the NUTS Foundation, and I work, most people have never heard of NUTS, but most people have heard about native healthcare. We are I think we're the largest IT supplier in the long-term healthcare, like home care, mental health care, disabled care. I'm not going to talk about that today. I'm going to talk about NUTS. So NUTS is, well, I'm a member of the board of the foundation of NUTS, but the real work is being done in an open source community by different IT suppliers, by people who are enthusiastic about our ideas and help us as a community. So the real work is done in the community, and we as a foundation, our only goal, our only means, a reason of existence is to support the community in the things that they do. So we try to have a very humble approach. Right, so what we do is we develop software to solve issues. Like we're a very technology-driven organization. One of the interesting things that you see in like other industries outside of healthcare is that sometimes things work together quite well, like email, for example. It doesn't really matter if I have an email provider like Google or if I use Outlook and a Microsoft Exchange server, I can still send emails to other people using other suppliers, right? And that's something that we all kind of take for granted. The same happens in mobile phones, for example. If I have a different phone, I mean physical phone than you, from a different brand or vendor, using a different cellular provider, we can still call each other, and that is all considered to be the norm. Why is this not the case in healthcare? Why can't we just send a medical record from one organization to another, even though they use software from a different vendor? This is simply not the case in healthcare. And this is one of the starting points where we started with our initiative a year ago, 4 years ago, I should say. And we identified that this has a lot to do with trust. And the way that we try to organize data exchange in the Netherlands has generally been from a centralized model where there's a party that we need to trust. And this hasn't worked very well for us. Now, I can't speak for other countries in the world, but here in the Netherlands it hasn't worked very well. And I think it's a practical issue because all IT suppliers have to connect with one organization and then exchange data through that organization, but also a legal issue where, for example, the Netherlands has a law that says if you want to exchange data via third party, then you have to have explicit consent from the patient to exchange through that third party, which also complicates things a bit. I see you looking. We'll save this one for the questions. Yeah, do that. So what we are trying to do, we as a NUTS initiative, is like be the simple mail transfer protocol of healthcare, right? So that's the thing that makes it work, that you can send email from one supplier to the other, is the fact that there's a protocol that has been defined somewhere in the 70s or 80s, and it has been used for decades now, and it's working very well. So we try to do something similar in healthcare. And the way that we do that is first we specify an open protocol. And this protocol then defines how to exchange data. Of course, I'll get back in a second to what exactly it is we're trying to specify, because there are more organizations that do these kinds of things. But what makes us kind of special is that we then implement that protocol in a piece of software that we call the NUTS node. And the NUTS node we give to everyone for free. It's open source, it's online, you can find it on GitHub, you can use it, everyone can just contribute to the effort, which makes for a functioning open source community, right? We started 4 years ago with a manifest, which is kind of an echo of what you said in your excellent framework for ethics in AI. But we use this as our framework for ethics in data exchange. And we use it as a way to attract organizations that feel the same way about data exchange in the Netherlands. And a couple of things that may strike you are things like privacy by design, security by design. May feel like obvious choices, but they are very often, unfortunately, still overlooked in healthcare. Right, to get back to what it is exactly that we do, we try to do one thing and do it well, like the Unix philosophy. So we are not in the business of standardizing dossier information, for example. We're not trying to say this is how you should register measurements and then be able to transfer them. There are other initiatives that do that, and FHIR is one of that comes to mind, right? So things like HL7, Health Level 7, do these kinds of things pretty well. In the Netherlands, we have NICTIS, who define zorginformatiebouwstenen. We're not trying to do that. That is the responsibility of other organizations. What we try to do is be the layer just below that, the layer that secures that data exchange when it happens. So enough about NUTS, let's talk about identity, because that's why we're here today. And I wanted to start with this slide. It's a pretty old slide. I think I made this 4 years ago. I just translated it this week. But it's still very relevant for today's topic, because these are the 4 things that we do, that we try to solve. So how can we identify people in a network that is decentralized by nature? How can we authorize people to do things in this network? How can we find each other, right? Both the services that IT suppliers provide on the technical level, but also the organizations in the network. And how can we see what happened in the network and who did what and when and why? And the funny thing is, if you want to do authorization, questions pop up like, on whose authority, who is the beneficiary of this authorization, right? And how can we prove that you actually have a valid authorization? Can we use a signature or something? So we need identification for that. And the same goes for when you try to build like a decentralized national register or international register. Who are you trying to find, right? That harkens back to identity. And is this source reliable? Do we have a signature on this registry entry? So again, we need identification. And the same goes for logging. Who did what? Who is the subject? Who is the actor? We need to be able to know who is who. And what's crucial to us in this network that we're trying to build is that we need to have a means of identification that gives us cryptographic proof, because we're not trying to all trust an organization with this, right? What we're trying to do is make a decentralized system where we need cryptographic security to be able to exchange data safely. And we use self-sovereign identity for a lot of these parts. And the way that we do that is, for example, we organize different entities to be like the trust anchors in this network. So for example, we can use the UziPass, which is a Dutch smart card that you can use, that healthcare professionals have, that they can use to communicate with others in the network. And we can use the UziPass as a means of credential, and we use that to sign things. Now, CBG, which is a Dutch organization, gives out this pass. Sorry for the Dutch-English mix-up. So that is one of the anchors of trust. And another anchor, we use the IRMA app, which is a self-sovereign identity app, and we then trust the credentials from the municipalities, right? So that is another anchor of trust that we use. So using these things, we made an application a couple of years ago, like a proof of concept, like a demo, where we have, for example, a general practitioner, and this general practitioner generally has to work with several other care organizations in her region, right, in her municipality. So the general practitioner at some point may want some information from these other organizations, right? So what we designed is a system where the GP can prove that they are a general practitioner and that they are a certain general practitioner, and then these organizations need to be able to check that that is actually valid, right? So this is a fairly simple and straightforward implementation of a self-sovereign identity app. I have something in my wallet and I'm able to prove that I am who I am, right? That was like version 1. Let's get to version 2, because one of the things that self-sovereign identity gives us, and that is, I think, underrated, is the ability to sign things. Not just prove who you are to one other party, but also set a digital signature under something. For example, this is me, and I'm using this software to make this request at this time. These are things that we can sign, and we use that because, let's say I'm a general practitioner, and I'm logging into my EHR system, right? And I use a self-sovereign identity wallet to do it. I sign that I am working with this software on my behalf, on my responsibility. Then my system, my EHR system, is actually the thing that is making the request to the other system of some other organization. Right? So what we can do with this signature is we can send it to the other system, and then the other system can independently validate and check that this is indeed that general practitioner, that indeed he is using that software, so the request is a valid request, right? And then give the appropriate response. So that's one of the things we need to be able to sign, like these requests for information. Another thing we need to be able to sign is, for example, authorizations in some cases. Right? In many cases, the authorization is done by a health professional who manages data. And in that case, you can do that in your own system. But for example, let's say we have like our envisioned perfect future where we have a nurse asking, can we share these records with your general practitioner? And you as a patient can then say, sure, that's fine, share these records. And the nurse says, right, we'll do, adds the general practitioner, and the general practitioner can look at your values, right? That's like the vision of the future. Now, the interesting thing is that we are advocating for the fact that the nurse is working in one system from one supplier, the patient is working in a system, for example, yours, and the general practitioner is working in yet another IT system, right? So to get this working, to get this ball rolling, we need to be able to trust this system from Ivido that this message actually came from the patient and that the consent that the patient is giving is actually a valid consent, like a valid authorization. So we can use, again, signed contracts using self-sovereign identity for that, which is very cool. And the final part of this is register entries. Like I said, we have a register that says what are IT suppliers, where can I find them, what are care organizations, how can we reach them. And this is a bit of a complicated issue because I'll try to keep this simple. Let's say Bob is a care organization and Alice is a care organization. Bob has some software that they use and they have a vendor and the vendor is Bob's software. And Alice, same story, Alice has a vendor and her vendor is Alice Software Solutions, right? Then there's a magical register in the middle. So the game that's at play here is that Bob at some point says, I'm Bob, I'm care organization Bob, right? And the Bob software has to ask the question, are you though, right? And we solve this today using contracts and checks, right? So we've kind of solved this trust between these two parties. But then Bob software says, okay, Bob is my customer, you can reach Bob through me to the magical register. And the magical register has to wonder, is he now? Does he actually represent Bob? How can we be sure? We don't know. We have no idea of finding out. And the same goes for the magical register saying you can reach Bob through Bob's software. How can I be sure? And then at some point, the software of Alice says, do you want me to send this data to Bob? And then Alice kind of has to wonder, I'm responsible for this data, right? What guarantees do I have here? Can I trust this? Because she has no idea. There are so many steps in this process that are questionable. Now the way to solve this, of course, is again using signatures. Because if Bob can sign a contract that yes, indeed, this is my vendor, these are the API endpoints you can reach me at, these are my keys, then we can send that through the whole network and Alice can actually trust that this works. And the fun thing is that the magical register kind of disappears because we can trust the contracts and it doesn't really matter how you exchange that data. Right. I hope that makes sense.
Only one question in the end? Or no?
I have only 2 slides left, so let's wait for 2 slides if you don't mind. I'll get back to the slide. So, right. Self-sovereign identity helps us with these things, and we're mainly focused right now on, like I said, the UZ pass, which is a governmental thing, and the IRMA app, because it is a very useful implementation of a self-sovereign identity wallet. That also has attributes that we can do things with from the Dutch municipalities. And they've proven very useful. And we're kind of hoping that as these things get more normal, using wallets and using actual cryptographic proof is getting more normal, that it will become also easier for healthcare professionals to use these tools, but also the other way around. If we can introduce these tools to professionals, to healthcare professionals, then they will take them home and use them for maybe their dealings with their government as well and makes self-sovereign identity more normal. Because of course we have hundreds of thousands of people working in healthcare in the Netherlands. Right, so that is like a very quick look at how we try to use self-sovereign identity and cryptographic proofs and tools to help normal people and care professionals take back control over where their data goes and when that happens and how that happens. And thank you, and I open the floor to questions.
I think we already had 2 questions. First.
Yeah, you were first. No. In the slide where you say software party A, this one. Basically, it's like a bank. So I have a bank account in a bank, and there's another bank, and there's somebody else has a bank account, and I have to trust the bank. The bank know each other, and the bank know me. So basically, that's enough. And it's not signed by me. The bank just knows who I am.
It's signed by you when you do the payment. You sign a payment.
Yeah, but the signature doesn't go all the way. The signature basically, as soon as the banks trust each other, they have a global entity in between.
Yeah, the structure is slightly different because banks say that that is your responsibility. You send money to somewhere to someone, and then you're responsible that you check the numbers and you know that that person has an account with that bank, right?
Yeah, it used to be also actually quite stupid.
Yeah, it used to be more trust-based, yeah.
The scalability of that system is very different, right? I mean, banks trust each other probably because there's a list of the banks that exist and that have been given a grant or something, where in this system you want a more flexible ecosystem.
I'm not sure because the health institutes that are recognized are also quite limited. They're not so.
Yeah, but the suppliers of these healthcare organizations are not registered anywhere. So the IT suppliers are many.
Maybe you should do that because banks have different software then as well. Maybe you should go then one level up to the institute. So let's say then you have a doctor software and institute. And institutes, they know each other and they can signal.
Yeah. Well, that's funny that you say that because that is also one of the things that we're working on now with the National Register of Care Organizations, the LRZA. We're working on getting the fact that you are a care organization as a credential in some form. Because then you can also use that to prove that you are a care organization, and you can use that in your contract with Bob software in this example.
You are becoming the SWIFT of healthcare.
Sorry?
You are becoming the SWIFT of healthcare.
The SWIFT of healthcare.
But it's already there. It's
You can use AGB. Actually, we give out that credential right now, the AGB credential, but that is not our role to have. And we would very much like to put that back where it belongs with either CBG or Vectis.
And one more level then, if this works, this is focused, and I understand it's difficult enough, so I don't say why are you so slow or whatever, but basically this is a local approach, and this is also a bit, you should do basically at least a European approach.
I agree.
I have been, I can talk about personal experience, I've been to European hospitals and it was a nightmare to get data back to the Netherlands. And it was really a big file, that was the only option.
I agree, and I'd love for this to start scaling internationally within Europe, why not across the ocean to the US or wherever. I think the approach that we take here of using open standards and open source software is very scalable, and we have very little influence over what people do with this. So I'm kind of hoping that at some point we get an email or a phone call from someone in, say, I don't know, Nigeria or Switzerland or wherever, saying, "Oh, we use your software and we've implemented a network here now." That would be awesome. I would really love to see that.
My experience is they will only do that when it actually breaks.
So given the time, Poppe, because you had the first question, we're now going to the last one.
Yeah, you spoke already about the UsePass. The UsePass, that's a PKI system. So it's already that everybody in healthcare, you know exactly what person it is and in what way he is registered. So you can use it, no trouble. So everybody can trust it because it's 100% sure. And the patient is also identified because they have a BSN involved. So also no trouble. So the healthcare professionals, they can communicate with each other, they can use the UsePass, with the private key and the public key, and they can even put the signature on the message so no one can read it, and they do this public key of the one they send it to, but they don't use it. But that is, then everything is no, But it's so only education, yes, for the professionals to do it.
But there has been a lot of education to use UniPass, and it's still not working quite well.
Yeah, but it's so the problem with the USPAS is that they are not aware of the value of the USPAS, because they give them to the assistant, say, you use my USPAS. Yeah. But so they are 100% responsible for everything what is starting with this, and then the hospitals, they are not fair enough to put a good penalty on it. They don't do it, and they should put a high penalty on it when the responsibility is not written down, and then afterwards he says, I didn't do it. It was his responsibility.
But that's the issue with all smart cards. That's the issue with all smart cards in the health sector, in the financial sector.
No.
Responsibility.
No, but it's your responsibility, because he has to sign to receive the card. He has to identify himself, so he knows that card he doesn't get for free. So he knows exactly that it's very complicated to get USPAS. They are all bullshitting about it. Because I did a big thing with USPASs, and it's so what you have, you should not throw away. And also with the patient, you have a BSN of every patient, so they can communicate about the BSN of the patient. No trouble at all.
A couple of things.
Make short, please.
I'll try to keep it short. Okay. So one is USPAS is definitely, I think, a part of the solution. But there are a couple of things that make it less usable. One of those is simply a technical issue, that the way we can currently sign things is not really using the card and the card reader, but using an external service over the internet. And I don't really, that's a technical issue that I'm sure we can fix.
They put it on the mobile and everything.
Yeah, exactly. So if we move that to a mobile phone, then that might be solved. But one of the other, I think, beautiful things about things like using the IRMA app and using your municipal credentials is that those have an intrinsic identification value, because you can use the same attributes to log in with your municipality or to get a mortgage.
The IRMA is not safe enough because it's not high qualified, and the USPAS is high qualified. So there you have a difference in security. And you should not communicate in difference of security, but of course this will be leveled down. Because the security of USPAS is nothing again.
I'm afraid I have to keep it short, but
Bob also. So
and then you mentioned that we have a citizen service number in the Netherlands, and we can use that to identify patients. Yes, we can between care organizations, but as soon as the patient tries to interact with it himself, we only have DigiD. And what DigiD does is not signing things. We can't sign anything with DigiD. So we have a lot of parts of the puzzle.
Same with DigiD as what you do with the IRMA. Of course, the level of security is the same level.
No, I'm afraid not.
To close this discussion, and maybe Hans in his further presentation maybe will be touched. I'm not sure. So, but would like to thank you again, Tim, for your presentation. And then we go to the last presentation. I think you have to switch mics. Interesting presentation. I must say, from personal experience, my mother had a surgery a couple of years ago in a hospital in Meppel, and then she went back to The Hague in order to come back to her doctor for any further treatment. And her the medical files were sent via mail, via just post to the hospital. And we had the appointment, I think, 3 months later. So we were there at the doctor and sitting and asked for the medical files, and he said, "Oh, I don't have it. You don't have it." No. Well, between hospitals, that is going well, but the internal mail within hospitals is not going well. So after 3 months, still was not there. So there's still some improvements to be taken, but like I said, it was a couple of years ago. Again, last presentation, Hans Niendieker, CEO of Ivido. Hans is going to talk more about, and I think Tim also touched a little bit, and I think he referred to you, Hans, about this, about seamless digital collaboration between patients, professionals, and also research through SSI. Something about Hans. He has a mission, patient empowerment and also collaborative care. You believe that both are crucial and necessary developments for sustainable healthcare. that's why I think you also founded Ivido for this part, to support the empowerment of patients, but also the health of every human being. So that's really great. So looking forward also to your presentation regarding seamless digital collaboration between patients, professionals and research to SSI.
Thanks, Robert. Thanks for being here. Nice to see you all in this atmosphere and not being at home after a screen. So it's a good thing. I want to talk to you about putting some kinds of what Tim already told us into practice, because we already use IRMA, we already use things like PGOs of personal health records. That's why I founded Ivido. That is one of the first personal health records in the Netherlands. But also I'm the CEO of HINK, that's a corporation, a healthcare corporation, acting in the fields of healthcare, which brings together a lot of healthcare organizations to work seamlessly together. That's the second thing I do. So I have two roles, as a founder of Ivido, and I'm the CEO of a network healthcare corporation, HINK. And what we're trying to do here is putting our mission into practice, patient empowerment. We can do that via PGOs, or personal health records. But that is empowering the patients with giving them control about their data. But there is a second thing to it, because we want also the healthcare providers to cooperate better across and with the patients if they are sick, but also to stay healthy. So that's the two things I want to do, putting the patient into more control, but also see to it that there is better collaboration and borderless collaboration between the healthcare providers. And we're doing that with our interoperable platform, and we're using techniques like IRMA, but we're also using techniques like NUTS to solve some issues for permissions and that kind of stuff. So we are in a role of the, let me first talk about why we need this transition, because I'm not everybody's in the field of healthcare, I think, but I'm for a long time now, and what we see is what we discussed, a lot of healthcare organizations not working together. I was in the field of chronic pain. I did a lot for chronic pain patients. And there was a pinball machine. They really got into the pinball machine, from the GP to therapists to the hospitals to back from all over the place. And the patient is not in control about what he is or she should do in that pinball machine. So it gives a lot of frustration to the patients. It is very expensive to do so. They don't have any control about their data, because they can do that via portals, but that's not having control about your data. You can see it, but nothing with control. And you have to tell your story over again, because your healthcare providers don't really cooperate or exchange information between each other. We have different languages. GP talks in different languages in the hospital, and all other healthcare providers do also. And you can log in what we know portals, but that's what we call minefield, because it's mine this, mine this, mine this, and everybody has his own portal, but it's not collaborating within your data. The second problem is because the healthcare providers cannot work closely together. They work in silos. It's organized this way in the Dutch healthcare system. And the information cannot be changed. It cannot be easily interchangeable. So you cannot, it's difficult because it's also, you have to act all according to the GDPR of the AVG in the Netherlands. And there's a lot of questions already. Tim raised that questions, which has to be solved. So there is not a base of trust in the Dutch system. And that's crucial for information exchange and collaboration. So in 2011, we had the big idea of having one big system, one big EPD, electronic patient directory in the Netherlands, but that didn't work out. We supplied, in the last 5 years, I think, MedMij, the Dutch system for interoperable exchange between healthcare providers and the patients, became active and was developed in the Dutch system. So there are two parties in that role. There is a patient who has really a role in that, because you are allowed as a Dutch citizen to get your information in your PGO or in your personal health record and having control about that data. And there is, of course, the suppliers of the healthcare information to that PGO. But it's important that there is not only supplying information to the Dutch patient, but also giving the information back to the healthcare provider so they can really use it. So it's two ways around, it's not one way. So that's what was implemented the last 5 years, I think, in the Dutch system. And then we became, with Ivido, the first PGO, which is applying to the MedMij rules. It's not a centralized system, it's a rule-based system. They control the rules, but there are now 35 PGOs in the Dutch healthcare system. So there is a lot of money invested in that system, in all kinds of VIP programs to accelerate the information exchange in the Dutch healthcare system. Now, how we have implemented this now, and it's already working because you can download your PGO, in this case Ivido, and you can really get your information nowadays from your GP. It's possible. You can do that. So you can do that with your PGO, which is MedMij certified, of course. You can have control of all your monitoring apps and your e-health apps to this, and you can have exchanges also with your social network, for your caregivers, for example. That's also very important. But on the other hand, the information has to be exchanged, because it's not only the patient or the Dutch citizen who wants to use that information. All the healthcare providers in your healthcare network, should also have access to that information. Because it's important for them, and patients rely really on that there is information exchange between them. Because if you go to your GP or you come from your hospital, you expect that your GP knows what has happened. That's what a lot of Dutch citizens think that is happening, but it is not the case in many times. So we created in the middle a collaboration platform. It's called the ZNO, Zorgnetwerkomgeving. Sorry for the Dutch terms. And HINK is also certified to get that information from all the caregivers to the personal health records of PGOs, but also to share that information with permissions to the other parties involved when you have a treatment relationship, of course, with that patient. Otherwise, you are not allowed to access that data. So for this permission things, we use NUTS. And we also only use standards, information standards, defined by MedMij or NICTIS. That's the only thing we talk, because otherwise it won't work. And why do we need then a flexible identity framework to do so? Because we have different roles in that system. We have different kind of identity providing systems in between and with the PGO. So what we're trying to do here is we're collaborating together with Radboud Security and the Privacy by Design Foundation, Bart Jacobs, and we started to use three years ago IRMA to have our own app, which we believe that is the future of identity providing. It is all the process. Tim explained how it works, but we really use it in practice. So we're giving them control about the patients, and we check the identity via IRMA to have access to your PGO. Otherwise, you cannot access your data. And also, and that's necessary because now DigiD is for a lot of people difficult. You have to access your data. You have to find all your data together. You have to log in several systems of 5 times, using 5 times DigiD to get all your information. You cannot enter. It's the My system that works that way.
I have no trouble with it, but that's my problem.
No, but you cannot access your data.
Of course.
No, you cannot access.
I can have my data, no trouble.
Yeah, but you cannot access your data from your GP, from your hospital, or your practice at one time. You have to log in every time for every single health caregiver. So that's...
It's not one login and then you can go everywhere.
No, it's not one login and then you can collect all your data. You have to log in 5 times. And if you are in a patient with several diseases, you are with your hospital, you are with your GP, you have several healthcare providers. So you have to log in every time.
With the PGO, it's arranged for they will collect that for you.
Exactly.
Yes. With the PGO, that's so MedMine. They have solved it.
Yeah, and what we want to do, if we have things, different solutions like IRMA. We can have one control. You don't need to remember your password because IRMA has your credentials. You log into your PGO and you say, well, I want that information from all my healthcare providers, and you are able to do that. That's what the future should be. One QR code, simple, get all your data because your credentials are clear.
And that doesn't work with the
No.
So I don't understand why 2 different identities cannot do the same thing.
Because we can't use BSN in the PGO. We're not allowed to use BSN. We only...
So it's an issue of access, not about identity.
It's legally not allowed to use the BSN, my unique ID number, used by the government. You cannot use it outside of the government domain.
A slight change of law will change the world.
At the same time, what we see in healthcare, the field of healthcare, also a problem. But we have the UCI pass, but it's not used by every Dutch healthcare provider. If every Dutch healthcare provider would use UCI pass on an appropriate way, we wouldn't have that problem as we have now, because a lot of them are not using the UCI pass, so it's not validated for all healthcare providers. So we need more flexible, more dynamic. It is designed for, we have a siloed healthcare system, and healthcare is more going to a network healthcare. So there's not one party, not one. Can have a lot of healthcare providers from different healthcare institutions. So you have to be, you need a real flexible system to do that. And that's why we want to use also techniques like SSI to gain access to that. But we don't have any good registers now. We only use the AGB codes from the Factis organization to check if the healthcare providers really is a real healthcare provider. So how we use that? Now, you have still the PGO here. We're using now this for IRMA. And we also gave access to the ZNO via IRMA. So that's the same credentials as you have from your community. But here we check extra for your AGB code. And then you get access to your ZNO. That's what we do. In the middle here, we are implementing NUTS to have, and of course the nodes over here, so we can interchange with all the healthcare providers. That's what we do now with IRMA and SSI. In the future, we want to go to the next step. We want to still use them there, but we also want to create fair data points. And that's for the researcher or for AI developments. So we create from the data in the PGO and data in the ZNO fair data points so researchers can access that data and also with the right credentials to access that data in a fair data point. So that are the developments we are making. So this is already in place. This is the future in the next 2 years. Any questions?
So it's not like a single sign-on because you use 3 times IRMA and it's not a single sign-on between them.
We have a single sign-on here.
Yeah, 3 months there.
But there's not every system. We have single sign-on with Chipsoft, with pharma partners, Medicom, but not with every APD. So with the APDs we are not have a single sign-on. They can use IRMA. So it is available for everybody. So single sign-on is easier because you can directly from your own patient records to the ZNO and have an extended version of that record. But if you are not have an SSO from your APD, you can use IRMA to log in.
So it's another login.
It's another login. Yeah.
And the consent is given where?
The consent is explicitly given by if we start here a treatment relationship between the ZNO and the PGO user. It's a digitally signed. And when there is a treatment relationship between your healthcare network and the patient, it is an explicit permission. Because we ask the patients to share that information, if we can share that information to the healthcare providers included, and what information, with what goals, so it's all according to the rules. And that's an explicit information.
So that's a consent that you give in IRMA so that other people can access your data.
Yeah. And we also work with the registers, National Register MIDs, and with the NUTS notice to exchange that information between the healthcare providers.
Another question. Yeah, so I'm a little bit puzzled about the use of the word consent here. How can I interpret consent as in GDPR consent, so freely and willingly given permission to do something with my data. How can that ever be applied here, given that if I do not give consent, I might ultimately run the risk of dying because my practitioner doesn't have my data. So there's nothing free about my ability to provide consent. I cannot simply go to another place to get this data because there's typically only one place where this data is. So how does consent work here as a legal mechanism? I don't understand. And I'm really cheating here because I work for research and education. We have a very similar problem. So I'm really anxious to learn how you guys solve this.
What we do here is we have the access to all the information from the source systems. Yeah? We ask the HINC. HINC is a cooperative healthcare organization. Yeah? You can be a member of it, and if you are a member of HINC, we are allowed to use BSN and everything else here.
So HINC is instead of the PGO?
No, HINC is the healthcare part, because this is your private domain. It's the citizens part, the patient part. It's 2 different parts, 2 different legal parts. You cannot access your data via a PGO because not every healthcare provider can work in a PGO of the patient. So this is the collaboration environment in which all the data, it's more a data lake from all sources and from the PGO are collected or can be accessed because we do not save that information again. We can collect that information when a question is raised. What we do is because we ask the patient in a treatment relationship with a blended healthcare, we ask the patient, are you willing to have that treatment relationship. It's what GP and all normally do. Yeah? They ask if you want to have that treatment relationship, but also digitally. So, and in that question, if that's according to the WGBO, the Dutch law for the healthcare, you have to provide that information, you're explicit, and if the patient says yes to that, yeah, they can exchange that information.
This is execution of contract or something like that. It's not consent. As a legitimate reason, I would say.
Why not?
Well, because it isn't. Because as soon as this is the relationship, you are providing the data because you're consuming a service from your practitioner, so to say. And to be able to execute that, the user.
But if the GP doesn't have access to your information, he can't do his job.
Exactly. So by definition, there cannot be consent. But so you can't use it exactly because of this. You can't use consent as the legal reason. There must be some other reason, and apparently, from what you just told me, it's execution of contract. But that does require contracts in place. That's my point.
What the best thing we want to do is to have access, give the PGO user access to their permission, so they can control in the PGOs what permissions they have given, and they can also withdraw that. So that's what we are giving them now. Yeah. So they are able to control that. Yeah. But the consequences when they don't give permissions to their GPs is that their healthcare providers can't do their job.
Exactly. So by definition, that makes consent not usable in what you just described. Because there is no way you can freely and really give this consent, because otherwise you...
But you can choose your healthcare provider. So you can say, well, I'm not trusting that GP, I'm using another GP. So
what's more control than consent?
It's maybe transparency, I would fully agree to that. Yeah. But then but then the word consent is super confusing. And I'm also not entirely sure if you can freely choose, because I actually cannot choose to go to a different hospital just like that, because this hospital might actually not be specialized in cancer treatment or in whatever. So
but there's no freedom. There's not ultimate freedom for every. You cannot have every care in every hospital. That would be very expensive. So of course that's the case, but that's the Dutch system. Huh? We have two ways to control that. We give that more transparency to the patients right now via SPGO. That's something, and we control that with IRMA, so we know if the identity, and we give access to the healthcare providers more explicitly, because now the permissions are controlled in the systems, and the patients don't know anything about what permission is given to whom.
Anyway,
I think it's good to do a wrap up there, because I don't think we're going to solve it today.
My neighbor is aiming at the definition, because you cannot retract the consent. It's going to terminate the relationship with the practitioner.
It can be, yeah, it can be the case, because if you stop using that exchanging that information, giving that permission, your provider, your healthcare provider, your GP or your specialist is not able to do his job anymore.
It kind of depends, I think, on the situation. But this is one of the reasons why we use the term authorization, because there can be
maybe that's better.
There can be multiple legal reasons to exchange data. One of those is consent.
Exactly.
There are many more legal reasons to exchange data, so we speak of authorization. But I think that what you're also referring to is there is a split between being treated and having your data exchanged digitally. And for example, with the corona shots now, you can consent to have your data being sent to anyone or not. In both cases, you get a shot. In both cases, you get a QR code. So the consequences are not always that you are not being treated if you deny data exchange. So in many cases, yes, there is a choice, but in some cases, yeah, you're right.
So what it really made clear that speaking 1 hour and 15 minutes about this topic is too short. So that's clear. I think we can fill a whole day. So and I found it rather interesting to hear a lot of things that are going on within the healthcare domain. So and still are improvements to be taken, but it's all based on maturity or based on other insights. So again, Hans, Tim, and Nupur, thank you for your presentations. Thank you for being here. So we have to close here, we have a short break, and then we have the last session regarding self-sovereign identity in the other room. So looking forward to see you there. Thanks.